Hello and welcome back to our series. We're grateful you're here. Before we introduce today's session, I wanted to let you know that you can find our updated programming and our latest newsletter on the web. We are always expanding our educational offerings, including our growing collection of programming led by Doctors Armin Smith and Jeannie Hoffman-Census and program team members Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg, specifically tailored around the experiences of women with bladder cancer. Our virtual women's group next meets on December 4th via Zoom. All relevant details can be found on our website. Simply Google Greenberg Bladder Cancer Institute. As we move into the fall semester, we are excited to kick off our latest series of virtual grand rounds for the bladder cancer community. I'd like to highlight our next session featuring Noah Hahn, Deputy Director of the Institute, along with a patient advocate sharing their story about what it's like to be enrolled in a clinical trial. The Zoom session will take place on Tuesday, October 10th at 4 p.m. Eastern. Also, keep your eyes on your email inbox for announcements about our new non-muscle invasive bladder cancer multidisciplinary clinic, led by urologist Max Cates and oncologist Noah Hahn. We're excited to provide this unique offering to the NMIBC community. Again, more information for all of our programming can be found on our site. Just Google Greenberg Bladder Cancer Institute. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm grateful to all of you for joining us today for a conversation about urinary tract infections and basic anatomy for bladder cancer patients. Institute co-founder and advocate Stephanie Cooper Greenberg will moderate the discussion featuring Doctors Nirmish Singla and Marissa Meyer-Clifton, both associate professors of urology, to explain UTIs and their impact on bladder cancer. First, I'll share a quick update, and then I'll bring our Institute co-founder, Stephanie Cooper Greenberg, in, who is the master of helping us frame conversations for maximum utility amongst our community. So we'll start with some slides from Doctors Clifton and Singla, and then Stephanie will lead us in a round of questions and answers. So please feel free to type your questions into the chat. So just by way of update, many of you may have seen this already. We've been waiting a long time for this. So the intravesical therapy Adstiladrin was approved last December 22nd. And I'm proud to say that the first patient has been dosed, and we at Hopkins are going to be among these first institutions to be able to offer it. Max Cates is in charge of negotiating that. So stay tuned. Very good news for the bladder cancer community. So now I guess I'll pass it over to Dr. Clifton.
Thank you so much, Dr. McConkey, and thank you everyone for having me today. I am going to just give a brief talk before Dr. Singla steps in, and I really feel honored to have this conversation today. I am a female urologist, but I've also, by way of just passion for patients with bladder cancer, started working closely with the bladder cancer team, and it really is a true honor to be here today. So I'm just going to start off with some basic concepts, and then Dr. Singla will come in with a few more thoughts, and then I'm really excited about the conversation that we're going to have. I would encourage you to type any questions in the chat, and Stephanie will make sure to bring it to our attention. So I think the most important thing is to really understand what a urinary tract infection is, a UTI. And it can be people say, oh, I got a test. I went to my doctor, I got a test, it showed bacteria, therefore I have a urinary tract infection. It's actually so much more broad than this. A urinary tract infection must include symptoms. So patients have to have consistent symptoms that are worse than baseline. Evidence of inflammation, meaning that when you get a urinalysis, that they see some sign that your body is reacting to those bacteria, and then a positive urine culture. Those three together are really what define a urinary tract infection. I think that's really important because if you go to an urgent care or primary care doctor's office, they may say you have a urinary tract infection just because of a test. So be mindful of that. Now, we talk about urinary tract infections in different ways. The uncomplicated urinary tract infection only applies to a very specific patient population. That is women without any structural abnormalities or comorbidities. And we know in a lot of our bladder cancer patients, that's not actually the case. A lot of patients have had repeat procedures, surgeries on their urinary tract, and they may have comorbidities or they may have urinary diversions. So complicated urinary tract infections, basically everyone that's not an uncomplicated urinary tract infection. So just be mindful when you look on a website or you go somewhere else, they may say, oh, this is how you treat this. Just be mindful there are different groups, and I think our bladder cancer population falls outside. Now, when patients with uncomplicated urinary tract infections, we don't usually have to do too much investigation. We talk about their history. We definitely need to do a physical exam. I always get a urinalysis and a urine culture, and I always check to make sure the bladder is empty. It's very important in patients in general to make sure that you don't have a bladder that doesn't empty, and that's why you always are growing bacteria. But in patients that have bladder cancer, it's kind of a different story. You usually are having repeat cystoscopies, have different segments of bowel that could be utilized if you have a reconstruction. So you may require imaging or cystoscopy. And a lot of our patients are already getting routine cystoscopies. So these are important considerations. So treatments then don't always apply. I do want to highlight that fluoroquinolones or those antibiotics that may have a black box warning for tendon rupture, they're actually not indicated as a first-line therapy. That being said, patients that have confounding factors or resistance profiles may need to have this antibiotic, but it's not the primary antibiotic that I use for patients with uncomplicated UTIs. Now, it's important to know the difference with different antibiotics. And in uncomplicated situations, we don't actually need to treat for weeks on end. You're thinking about 3 days for uncomplicated urinary tract infections. And some antibiotics are more bacteriostatic, meaning that they don't directly kill, but they kind of hinder the growth. And so macrobid or nitrofurantoin needs to be a slightly longer course. Most of the time when you have the bacteria and you have the culture, you know the right antibiotic 100%. So you can be on that antibiotic. And we know that when patients are put on those antibiotics, the bacteria are eradicated. Their urinary tract infection is done, but their symptoms may persist, and I'll talk about that in a second. We also know in uncomplicated urinary tract infections, we may not even need to treat them. They may just wash out on their own. So up to 30%, maybe even a third of patients will call in, I'll get a urinalysis and a urine culture, but their symptoms will have resolved by the time we get the results, and therefore I don't give them antibiotics. But in complicated urinary tract infections, so in men or patients that have any of those comorbidities or surgeries, you need potentially longer courses of antibiotics, and you may also need further investigation. So when my patients come in and they've been treated appropriately, some of them, I'd say there's a good portion of them may have persistent symptoms. And it's really important to know that symptoms do not say you have a urinary tract infection. It's the three things. It's having the symptoms, evidence of inflammation, and a positive culture. But if those symptoms persist, I always recommend making sure that you get another urine test, that there aren't new bacteria that have come in or the bacteria are still there. But another question is, are you taking the medication as prescribed, making sure that you follow the pharmacist's direction related to the antibiotics? But something else that I do, because I know how impactful urinary tract infections can be on patients, is make sure that they're able to empty. If you're not emptying well because everything is tight and it's very uncomfortable to urinate, that can also create symptoms. And then in my female and my male patients, I usually do an exam to make sure there's not something else that can be missing. I think it's very important for patients to know that sometimes, because of all of the inflammation that's caused from a urinary tract infection, you really do get a full body response, and your lining of your bladder can be very irritated. And that bladder inflammation may be persistent for a period of time, and it may take time for that to resolve. And so sometimes when you have a negative culture and you still have symptoms, we do other symptomatic management outside of antibiotics to help you feel better. And this may include overactive bladder medications, meaning medications that help calm the bladder, a urethral numbing agent like Pyridium. Sometimes it's just changing in behavior using anti-inflammatories. And we really want you to be healthy and avoid constipation during this period of time. So if you do have symptoms after your bacterial infection has been treated, we have ways to make that better for you. And don't say antibiotics are just the thing that we need to do. If you go out in the community, they may just say, oh, we're going to put you on another trial of an antibiotic, but that may not be the best answer. So another conversation topic that I think Stephanie's going to ask about is about preventing reinfection, because some patients that have infections are more prone to have infections again in the future. And how can we optimize our patients to minimize the risk of getting an infection again? In women that are perimenopausal or who have gone through menopause, I love topical vaginal estrogen. Again, it's topical. It's not a pill that you take that goes throughout the bloodstream. It's really a locally acting medication that does a lot of important positives to change the urinary microbiome and the vaginal microbiome. Oral cranberry supplement is something I get asked a lot about. The data hasn't really shown a huge benefit as of yet, but I think if my patients find benefit and it doesn't cause harm, I support anything that I can do to make them feel better. Now, I do think that the pills are better, especially the high concentrate pills are better than cranberry juice. If you think about it, cranberry juice can have a lot of sugar. It can exacerbate diabetes, so it may not be the best avenue to try to prevent recurrent urinary tract infections. So there are medicines that are out on the market that are over the counter that you can try, but again, still limited data on how well they work. Some people are given D-mannose. That's thought to impede the ability of the bacteria to adhere to the lining of the bladder or the urinary tract. Again, some of the studies show benefit. It's not as inspiring as we hope, but again, if it doesn't cause harm, I encourage patients to try what makes them feel better. Methanamine is basically a medication that's taken orally. You take it with vitamin C, and it breaks down into a chemical called formaldehyde that's supposed to kind of sterilize the bladder or the urinary tract. It's very important that you take the vitamin C with the methanamine, or it doesn't work. And again, I would not use that in patients with bowel diversion. It's not a good idea. It can be absorbed throughout the bowel. So some of my patients do take this medicine and they have seen benefit. It can be costly, and make sure that you use vitamin C with it. Some physicians or providers give patients self-start therapy. I think when you're dealing with complicated urinary tract infections, that can be a little bit challenging because there's so many reasons people can have symptoms, and we want to make sure that they're on the correct antibiotic. So I tend not to give a lot of self-start therapy. I also don't give a lot of suppressive antibiotics. Sometimes people call it prophylactic antibiotic, taking an antibiotic every day to minimize the risk of getting a full-on urinary tract infection. But really what that does is breed resistance. It can change your bowel microbiome and cause a lot of other issues. And so I generally do not start people on suppressive antibiotics because of those potential risks. And also when you look long-term, it doesn't decrease the frequency of symptomatic recurrent urinary tract infections. Now, another concept that I want to bring up to this group is a very important one, and that's called asymptomatic bacteriuria. What does that very, very long term mean? Well, it means no symptoms, but you do have bacteria in the urine. So the analogy that I use is I'm a physician. I'm in the hospital all the time, and my skin is colonized with all types of bacteria. These bacteria usually aren't causing a problem. I'm using Purell, I'm using hand sanitizer, I am being as sterile as I possibly can, but we know that that bacteria lives on your skin. So if someone were to get a swab and rub it on my skin, they would grow bacteria colonies. Now, does that mean I should be on an antibiotic? I think the entire group would say, no, that doesn't mean you need to be on an antibiotic. So I use that analogy. If you have bacteria that live in your body and they are not causing a body response, then we shouldn't be proactively treating them, with a few caveats that your surgeon would direct you about. So asymptomatic bacteriuria, or having bacteria in your urinary tract without having symptoms, very, very common finding. We see these in bladder cancer patients that have had urinary diversions, right? Because you're using pieces of bowel that are populated with bacteria to reconstruct bladders or drainage systems. You also see in patients that have never had bowel diversions or large surgeries. We still do not treat it. The only patient population we treat for the asymptomatic bacteriuria are pregnant women to reduce the risks of having birth complications. Other than that, we leave it alone. So I just want to let the group know about that concept because that helps you make decisions about your therapy going forward. Now, in urology, we do a lot of procedures. So as surgeons, we're operating on the urinary tract. That's another caveat. We do want to treat people before we go in and do biopsies or large surgeries to remove the bladder or reconstruct the urinary tract. So really, I think everyone should be mindful of this because if you go locally, they'll get a urine test. They may tell you you have an infection and then bacteria should be treated. But I encourage every patient to be empowered to know their own body and when it's right to treat an infection versus realize it's not an infection because infection requires symptoms, evidence of inflammation, and a positive culture. And if you don't have all three of those, it's probably not the best idea to be on an antibiotic. When people are on antibiotics, they get resistances, they get side effects from the medication, and we'll talk about that in a second. And it's not just me as a urologist telling you this. Actually, the Infectious Diseases Society of America has a position statement saying that we really should not be treating the bacteria that are colonizing our urinary tract, and we need to be thoughtful about what other things could be going on. So why do we avoid treatment of this? Well, you can have adverse outcomes. You can get colon infections called C. difficile colitis. You get resistances. So the bacteria become smart and they don't respond to our normal antibiotics, requiring IV antibiotics, prolonged courses of antibiotics, or even experimental treatments. People have all kinds of drug effects from these medicines, upset stomachs, nausea, vomiting, skin changes, all different types of things can happen as a result of long-term antibiotics. But I would argue the main reason to not do just plain treatment of asymptomatic bacteria is I'm not going to make the patient better, or if there's an underlying problem, such as bladder cancer, or such as overactive bladder, or other things that could be contributing to these symptoms. If we blame it all on a urinary tract infection, we're never going to get to the basic cause of their symptoms. And I think people on this webinar may be familiar with the idea that especially women are diagnosed at later stages of bladder cancer because they've been blamed as having a urinary tract infection when it's really been a bladder cancer that has been brewing and they haven't had the evaluation. So I'm a firm believer in making sure that we listen to our patients and that we evaluate clinically if someone should be on antibiotics, and if they're having blood in the urine and they do not have a urinary tract infection, that they need further evaluation so that we decrease the incidence of bladder or the progression of bladder cancer in our female patients and other patients as well. So I want to make my patients feel better. I want to make sure I'm not missing something. So I tend to do a lot of cystoscopies in patients with visible blood in the urine and patients definitely with microscopic blood without evidence of a bacterial infection. I want patients to feel better. Now, that being said, in patients that have had urinary diversions, or if you have other conditions, if you get signs of a urinary tract infection, or someone gets a urine culture and they see you have bacteria, or urinalysis and urine culture, and you have bacteria, if you have fevers, that needs to be treated. Fevers need to be taken seriously. People can have really bad infections and they need to be treated in a timely fashion. So everything I gave you ahead of time was around simple urinary tract infections, not patients with fevers or may have bowel diversions with fevers, because we're going to treat those in a very different way. So that is my caveat. If you are sick, you get the antibiotics and you get treated so that you feel better, and then we can work on the simple bladder infections down the road. I do want to go back to vaginal estrogen briefly before Dr. Singla takes over. Vaginal estrogen has brought about a lot of fear in women that are postmenopausal, and I think a lot of it is not fair, and it's been perpetuated by us in the medical field. Vaginal estrogen is very safe. It's topical. It is a therapy that's out there. In fact, it can do so many good things for our patients, including improving urinary symptoms, improve pain with intercourse that's penetrative, and prevent recurrent urinary tract infections. But a lot of concern was raised based on the studies in the 80s that looked at oral supplementation at very high dosages of estrogen. What we have now found is that that's not the case. We're doing more and more studies demonstrating that vaginal estrogen does not increase the risk of breast cancer. In fact, the position statement for the American College of Obstetrics and Gynecology states you can give patients vaginal estrogen when they're getting treatment for their breast cancer. And I think that says a lot. That being said, we're looking at large groups and we're comparing if you give patients vaginal estrogen after they've had a breast cancer diagnosis, does it increase their risk of breast cancer? And we are not seeing that. In fact, there is some data to suggest that it's preventative for deterioration, and these patients that are on vaginal estrogen may live a longer life. Now, I think there are a lot of confounders there, but it's probably related to improving quality of life and activity that has resulted in these findings. So again, vaginal estrogen is a great therapy, and I think it's safe and effective for the appropriately selected patient. I'm also a huge fan of physical therapy. So many of our patients have faced pelvic floor trauma, either through surgery, through repeat looks in the bladder, through recurrent urinary tract infections. Physical therapy is a way that we help train our body to recover from those traumas. And physical therapists are all different. So you have to go to a specialist that really understands these conditions. And really, your ability to recover from some of these issues are completely dependent on the physical therapist that you work with. So work with your surgeon, with your physician to find a good physical therapist that meets your needs. And I want to just give a plug for the Women's Health website that can give you a way to connect, even if you're a man. This is a great resource because it talks about pelvic health, pelvic floor trained physical therapists outside of the Baltimore area nationally. So you may be able to plug in with one of the physical therapists that are associated with this group and get some really good directed physical therapy for any of your urinary complaints. And so that was going to be my slideshow. And now I'll hand it over to Dr. Nirmish Singla, who's going to give us a different conversation about urinary tract infections.
Right. All right. First and foremost, welcome everyone. This is really an exciting opportunity to share some insights about urinary tract infections, and Dr. Clifton's act is definitely going to be a hard one to follow. I think she did a really tremendous job giving an overview of urinary tract infections and many of the common questions that we receive pertaining to UTIs. I just, my talk is not going to be quite as long or detailed, but I thought that maybe I would focus my portion on the nuances of UTIs as they pertain to the bladder cancer population. And in particular, the areas I wanted to focus on included both diagnosis of UTIs, but then also the what the implications for bladder cancer patients may have, either anatomically or based on repeated instrumentations on the incidence of UTIs and how to address them. So I want to emphasize something that Dr. Clifton already brought up, which is that oftentimes bladder cancer, especially in women, may be delayed in terms of its diagnosis. And this may be simply attributable to the fact that many of the symptoms that are consistent with an active UTI may actually also overlap with those that you can see in the setting of bladder cancer, such as, for example, blood in the urine, or irritative urinary symptoms like frequency and urgency, or sometimes discomfort. And so it is certainly important that guidelines are followed and adhered to as it pertains to evaluation of certain types of symptoms, namely the blood in the urine, because that may actually be a way to detect bladder cancer that otherwise may masquerade as a UTI. In terms of bladder cancer as a risk factor for developing UTIs, there are some specific aspects that pertain to routine management of patients, both in the non-muscle invasive bladder cancer space as well as in the more advanced setting. And this also pertains to patients with upper tract urothelial carcinomas. Most importantly, for the non-muscle invasive space are essentially patients in whom we are not pursuing radical treatment of bladder cancer. These are patients who often necessitate repeated instrumentations of the urinary tract. So for example, routine surveillance cystoscopies or ureteroscopies in the case of upper urinary tract disease, or the need for repeated catheterizations for topical therapies, or in other words, intravesical therapies given within the bladder. These are potential ways that bacteria can be introduced into the bladder itself. Furthermore, the types of therapies that are sometimes utilized, such as, for example, BCG, most commonly in managing non-muscle invasive bladder cancer, can itself have immunologic effects that may impact one's likelihood of developing a UTI just from immunosuppression, for example. Furthermore, foreign objects like urinary stents or nephrostomy tubes may be necessary for selected patients with bladder cancer or upper tract urothelial cancers, and these may become colonized and they may form what's called a biofilm, which may increase the chances of having a significant UTI. There are also some nuances pertaining to the advanced setting, and I'll go into this in a little bit more detail on the next slide. Certainly, for patients who are undergoing radical cystectomy, there is a need to form a urinary diversion or some way in which the urine can be excreted. And this is typically done by refashioning a segment of bowel into some form of a diversion. And this, like Dr. Clifton had mentioned, is typically colonized with bacteria and can potentially increase one's risk of developing what we call a pathogenic or a clinically significant UTI that necessitates treatment. Furthermore, in the more advanced setting, we often will rely on certain forms of systemic therapy like chemotherapy or immunotherapy that may have effects on the immune system that may potentially increase one's chance also of developing a UTI. So I wanted to talk a little bit regarding urinary diversions, and this is something that many of the attendees here are already familiar with anatomically, but just to sort of give a brief overview again, when it comes to urinary diversions, essentially what we typically will do is take a segment of bowel, most commonly the small bowel, and then refashion it into some form of a diversion where the ureters that drain from the kidney get plugged into one side, and then the other side gets either rerouted to the abdominal wall or gets routed to the urethra. And so most commonly, we tend to employ ileal conduits, which typically don't tend to be a reservoir per se for urine, but rather just a conduit, if you will, for urine to then pass through the bowel segment into a bag that is then attached to the abdomen. But other forms of urinary diversions include continent cutaneous reservoirs, which are basically these pouches that are formed that require catheterization in order to expel the urine, and then orthotopic neobladders, which are essentially then connected to the urethra so that patients can simply void volitionally. So it's important to recognize, as Dr. Clifton had mentioned, that with the use of bowel segments, and particularly for ileal conduits and continent reservoirs, where either there's direct exposure to the outside or there's a need for repeat catheterizations on a routine basis, that inevitably the urine will be colonized with bacteria. And so these are patients who have asymptomatic bacteriuria. And in the majority of cases, these are situations that don't necessitate treatment because of issues related to, for example, antibiotic resistance, which Dr. Clifton had mentioned in more detail. That being said, there are certain forms of infections that can arise that are what we call pathogenic and do necessitate treatment. Another reason why patients are at increased risk when they have diversions for forming pathogenic UTIs is because the bowel naturally will make and secrete mucus, and this mucus actually can serve as like a scaffold, or what we call a nidus for infection. So the bacteria can actually be trapped in this mucus, and the risk of having the mucus or bacteria sort of sitting in the urine for prolonged periods of time increase the risk that some of these routine bacteria that we see in the urinary tract could actually become pathogenic or increase the chances of having superimposed infection. Likewise, in patients with cutaneous reservoirs or neobladders, the urine can sit for more prolonged periods of time, and that may actually crystallize into stones, which too can serve as a nidus or a scaffold for infection. Another thing to recognize is that the normal types of symptoms that one may associate with UTIs in the case of a normal anatomy typically would include symptoms like usually pain in the suprapubic or in the pelvic region, urinary frequency, urinary urgency. But it's important to recognize that in patients with urinary diversions, sometimes the natural sensations that one may experience in the bladder are no longer going to be there. And so there's a need to keep a lower threshold to recognize some abnormal symptoms, which may actually be indicative of a pathogenic UTI that would necessitate treatment. Some of these symptoms may include malodorous urine production, increased production of mucus, sometimes overall a decreased production of urine overall, or a generally more dehydrated state. Sometimes even just non-specific pain within the abdomen, sometimes even pain in the flank areas, or other more serious symptoms like fevers, or even issues with tolerating oral intake, nausea, vomiting. All of these are potentially within the spectrum of what a UTI could look like that would necessitate treatment. It's also important to recognize that in terms of getting a sample of urine, perhaps more relevant for patients with ileal conduits, it's important that the sample is not simply just acquired from the bag where the urine collects, because this is inevitably going to be colonized and potentially contaminated with other non-pathogenic bacteria that are not relevant to the treatment course. But rather, ideally getting a catheterized specimen, a catheterized sample from the conduit itself. For the cutaneous reservoirs, inevitably, this would necessitate catheterization anyway to get the urine out. And then in the case of a neobladder, it is actually appropriate to give a voided sample, barring any issues with urination. One other aspect that I just wanted to highlight is just this concept of reflux and what the implications are for the upper urinary tracts. And so when we make these conduits or these urinary diversions more generally, most commonly we are now performing what are called refluxing anastomoses, meaning that when we sew the ureters into the bowel segment, the urine has the ability more or less to flow freely in either direction. And particularly, this is of maybe greater interest for patients who have these pouches, either the continent reservoirs or the orthotopic neobladders, because as the urine will build up in these reservoirs, if it's not expelled at regular frequencies, there's an increased chance that the urine could essentially back up into the upper urinary tracts. And the reason this is important is because repeated infections within the upper urinary tracts could potentially increase the risk of upper urinary tract deterioration, or specifically renal functional deterioration. And this is something that we do certainly want to avoid, and one of the reasons why for patients with continent diversions are recommended to have routine emptying of the bladder. A little bit less of a concern in the setting of ileal conduits, but if there is an issue with the drainage of a urinary conduit or any form of obstruction downstream, these patients too could be at an increased risk of having reflux or backup of urine. And so there, again, like I had mentioned before, most of the time we don't tend to worry too much about treating asymptomatic bacteriuria, but there are some exceptions in which some clinicians may advocate for treatment. And the reason for that is to help decrease the risk of upper urinary tract deterioration. And this is more specific to patients who have been colonized with Pseudomonas or Proteus bugs. Most commonly are the ones we sort of refer to for patients who might need treatment. But every case is certainly nuanced. And so on that, I did want to leave an adequate amount of time to make this an interactive forum. Again, hopefully this was a good general overview in the setting of bladder cancer and UTIs, but happy to turn the floor over to Stephanie and Dr. McConkey to take the lead on the discussion.
Thanks, both of you. That was outstanding. Stephanie?
Wow, what a lot of information. Isn't that great? We really care about our UTIs for this population, and you both gave us like a really important dictionary of information, which, you know, oftentimes isn't really actually available to us. So thank you, especially in the context of bladder cancer patients. I have lots of questions, but first let's go to our wonderful audience who has submitted some. I will ask, and either Dr. Clifton or Singla, one or the other can answer it, or both. And let's get started, and then we'll have a great conversation. So the first question is, does having frequent bladder infections put a patient at a higher risk of getting bladder cancer. And this particular patient offers that they've had 2 low-grade urothelial carcinomas, non-invasive. So once again, if you have frequent bladder infections, assuming they are UTIs, does that put you at a greater risk of getting bladder cancer? What's the correlation there?
So I'm happy to sort of offer some insights into this question. So there has been a lot of interest in studying this, and so there are actually a number of some retrospective series and actually recent meta-analysis as well that tried to understand the relationship between UTIs and bladder cancer development. I think the bottom line here is that there hasn't really been any definitive causation or a causal relationship that having frequent UTIs causes bladder cancer. So I would say that we can't establish that as a cause and effect. However, if you do look at the literature, it does show that in patients and patients who are chronically colonized with bacteria, who have chronic UTIs, these are the patients who may be at an increased risk just by association with bladder cancer development. And in particular, one type of bladder cancer that we're that may be of interest in this space would be something called squamous cell carcinoma that's often associated with chronic inflammation in the urinary tract. And so there may be this association that has been purported, but again, I think it's insufficient to say that there's a causal link.
And just to augment what Dr. Singla said, is we do know patients that have indwelling urinary catheters or foreign bodies in the urinary tract that cause inflammation can have this squamous diagnosis, which is different than what a lot of our patients come in with, which is urothelial carcinoma. So I do think there are risks. And so we do surveil our patients that have indwelling catheters very differently than we do the general population. So for the person that brought this up, I don't think there's anything that you did or had done to you that resulted in this. Unfortunately, it's a combination of all of those life and lived factors and genetics that interplay that we don't yet understand, but Dr. Singla is going to get to the bottom of. I'm holding him to that, and Dr. McConkey as well, to make sure that we do have ideas that we can help guide patients in the future. But I firmly believe that our patients that have UTIs, unfortunately, are struggling with a very annoying problem, but I do not believe it directly leads to bladder cancers and what they're facing.
Oh, great answer. From Gary, this is a specific question about Levaquin, which is and tell us what Levaquin is. Why is Levaquin still being given for UTIs when it's a very dangerous drug? He offers that his Achilles tendon was damaged after only 1 pill. Levaquin comes with 8 pages of black box warnings for a rupture of the Achilles tendon, and he thought it had been taken off the market or discontinued. Can you talk to us a little bit about what Levaquin is and what it does to you and your Achilles tendon? That seems very unfair.
Yeah, it is. And, this is going back to the issues that we've faced with understanding the long-term effects of some of these antibiotics. So there is a black box warning for fluoroquinolones, and I actually don't prescribe them very frequently in my practice. They are not yet removed from the market, but we do have to give notification of this black box warning. And unfortunately, for patients that experience tendon issues, it tends to be this story. You've maybe had 1 dose or 2 doses, and yet you have an Achilles tendon rupture. There's very little warning when this happens, but we do know it affects a segment of the population. Now, there are some thoughts, and I'll let Dr. Singla give his thoughts related to the urinary tract and the diversion aspect. There are some thoughts that it is a very strong antibiotic, so it does penetrate a lot of tissues. It also can act against a lot of different types of bacteria. So previously in urology, we used to use ciprofloxacin and Levaquin, levofloxacin, quite a bit. And we've moved against that because of these issues. But Levaquin can actually have a 24-hour onset of action infection, which is really nice for our patients. Same with ciprofloxacin. However, some of the other antibiotics have to be taken 4 times a day potentially. So there are a lot of different factors that weighed in, but I think as we have patients on these medications for longer terms, we understand some of the side effects. And that's why it is so important to only treat patients when they have true infections and be mindful of that. And I know in my practice and in the American Urological Association guidelines, we've moved away from using fluoroquinolones for a lot of our antimicrobial prophylaxis. But I'll let Dr. Singla pipe in as well.
I think you hit the nail on the head there, Dr. Clifton. I think the most important thing here, there's a couple of things. One, as with any antibiotics, there's always potential risks and benefits. And this is exactly why our national organization, the AUA, is all about antibiotic stewardship, or essentially only being judicious with the use of antibiotics, only really using it in settings where it's truly necessary. And then the choice of antibiotic also, in general, Levaquin, ciprofloxacin, they are very much effective antibiotics, and this is exactly why it used to be that these were more routinely prescribed. But undoubtedly, as the denominator of patients increases that have received this medication, we're starting to see more and more of these issues like the Achilles tendonitis, et cetera. And so, now I think there is definitely a lot more caution towards using this on a routine basis. There are patients who would still benefit from this medication, and so it's not something that necessarily needs to be removed from the market. But I think that the more you prescribe this medication in a routine fashion, the more likely that you would run into these types of adverse effects.
I'm going to skip around a bit in the questions. We will answer them all. Karen asks on the same point, what would be the drug of choice? This is for both of you. What would be the drug of choice to treat a UTI if the patient is allergic to Bactrim and macrolides? Did I say that right?
Nitrofurantoin or macrobid or minocycline?
Well, first Bactrim, I can pronounce that one. Macrolides is the second reference.
Oh, macrolide. Yeah. So I think there are a lot. The really nice thing about getting a urine culture is that you're going to find exactly what antibiotic to use. And that's another reason I'm a big fan of growing it. Now, sometimes Dr. Singla and myself have to put a request in to make sure that they speciate, especially in people with bowel diversions. They tell us what bacteria is there so that we know the right antibiotic to use for all of those reasons. That being said, when you get that antimicrobial guide, it helps direct your therapy quite a bit. So I'm a big fan of Keflex, but there's also, if you have someone that's very symptomatic, you have a local guide that you can use based on resistance profiles. And so here at Hopkins, we actually have an antimicrobiogram that you can use to try to figure out if someone's really sick, what we should give them that's going to be the most effective. But really getting that urine culture and seeing what that resistance profile looks like is so important. And because of how many antibiotics that have been used in the past, I'm seeing a lot of patients with allergies and resistances. And sometimes we have to partner with our infectious diseases specialists to figure out the right program to use, because when you cannot take an oral medication, you have to get the IV medications. So I like Keflex. I think it's a really great, well-tolerated drug. It just has to be used 4 times a day, and it all depends on the bacteria that's grown and their resistance profile.
I'm going to ask a question in between here. So are you saying that if you are anywhere in the United States and you suspect you have a urine UTI and you get a culture, is the species always identified, or is that a step that people should be asking for?
Such an important question. So if you went to a local doctor that maybe wasn't an urgent care, they may just do a urine dip. That's where they take the urine, they put it a little drop on a strip, and they feed it through, I like to call it a dumb machine, because that's all it is. It's looking for some specific parameters, and it's not very specific. So if you went to, like when I was pregnant, I had that done all of the time. They're not sending that out to be looked at under the microscope or to have further culture done. They're just looking under a strip. Those are very, very unique situations that I would use that device. So if you're going and seeing somebody and they're just doing a urine dip, and people will recognize it because it says trace, small, occult, and has words. If they don't have numbers and they don't have a species, then that means you're not getting that full evaluation. And I think our patients that have complicated urinary tract infections, most of the patients on this call would benefit from getting that urine culture where they physically take a petri dish, they put the urine out, they grow the bacteria, and they put little discs that are covered in antibiotics to tell you the correct antibiotic to use. It's so important. So you have to think about this more broadly. And our patients that are on this call, we likely have a lot of confounders. And I think there is benefit to sending the urine off to be grown to make sure that we're on the correct antibiotic for their treatment. But you're correct, Stephanie, that doesn't always happen. The urgent care, though, is actually very good at doing both a urine dip, urine microscopy, as well as a urine culture. Whereas if you go to your primary or you just phone a friend or phone a doc, they may just put you on an antibiotic. And that's where I think we can have side effects and incomplete treatments.
Good to know. So maybe make sure you're getting the right specific test that tells you what you need, especially for our beloved population here with enough urinary problems. We love our urine, but we like it to be, treated properly. I'm going to go back for a few questions, and thank you for keep them coming. So for both of you or one of you or whatever, what do you think of one dose of a prophylactic antibiotic, Cipro, following a surveillance cystoscopy? Is that recommended or is it overkill? This is in the prevention department, I suppose.
Yeah, so I'm happy to take this one. Again, referencing our national guidelines, we're very much in the way of antibiotic stewardship because we don't want to promote issues with antibiotic resistance and side effects from antibiotics, especially like fluoroquinolones, Cipro, et cetera. So in general, I don't usually give for lower urinary tract instrumentation, relatively straightforward instrumentation that for which you're not doing a biopsy or doing anything else other than really going in, taking a look and taking out the scope right away. I don't generally give any antibiotics at that time, and the majority of patients don't have any issues from a standpoint of an infection. There have been some patients that may be prone just because of colonization of their bladder with bacteria or issues with recurrent UTIs in the past that may come to me and say, hey, every time I get a cystoscopy, I end up having urinary symptoms. And if I do receive like an antibiotic at the time of the cystoscopy, it seems to mitigate that effect. So there are maybe certain scenarios where I'll reconsider, and I think it's definitely on an individualized basis. If we think that the potential benefits outweigh the perceived risks, then I would consider it. But for the routine patient who comes in and is scheduled for a cystoscopy, I don't usually give any antibiotics.
Good to know. So different. Everyone has a different style, but it's probably great to not have to have a Cipro when you don't really need it. Switching gears a tiny bit, Brenda asks Dr. Clifton if there is which vaginal estrogen medication would you recommend, since you're a big cheerleader for it?
That I am. And I think that there are a couple of caveats. One, I want your insurance to be able to pay for it. So I don't think one formulation is so much better than another that you need to go one route or another. I think the key is making sure that it's affordable for our patients. The idea is that the vaginal estrogen, it goes into the vagina and it actually stimulates the receptors on the epithelium of the vagina and it causes them to grow. And what ends up happening with that growth is that the pH of the vagina changes and encourages healthy bacteria to move back in and forces out the bad bacteria. So it's all about making sure that it's vaginal. Even in my patients that have oral or patch supplements, I make use vaginal estrogen because the estrogen does not go to where it needs to be. So vaginal estrogen in and of itself, the key is consistent use. So if you use it once, but you forget it for 5 weeks, it doesn't do a whit of good. It's not a moisturizer. I think of it as a fertilizer. It's giving those estrogen receptors that response so that they're activated. So if you use it once and forget about it, it's like not using it at all. Or patients that say, I'm irritated right now, so I'm going to use it, and then I stop using it, it's really not doing anything. It's like using KY jelly in a certain sense. So really the key is to make sure you utilize it consistently. Now, there are different formulations. There's a little suppository that's called Vagifem or Uvifem tabs, and it has a little applicator, so it pops right in. Tends to be a little less messy, and that's great for people that are active. That being said, I still have people apply it at nighttime when they're going to be lying flat to allow the medication to be absorbed. The other aspect that's really important is if you're using the cream and you just use that comes with a little dispenser plunger, and if you just use it, it'll kind of just fall right out, and it tends to be very messy. So Rachel Rubin, who I think you've had on this programming before, used this great analogy when I was talking to her. She says, take your finger, put about 1 gram of vaginal estrogen, because you got the little measuring applicator, put it on your finger, and you basically just rub it in, not so that it's getting absorbed, but more so that it doesn't just fall out. So it tends to be a lot less messy for our patients. The other option is a little insert that's a ring, and that's great if it's paid for. You basically just pull it in and out every 3 months, and it slowly releases the estrogen. The key is the consistency and the slow release formulation. And in patients that maybe don't have as much manual dexterity, they can come into the office and we can change those rings out for them every 3 months, and they're getting that slow, steady amount of vaginal estrogen. It also makes our oncologists feel a little bit better because they're getting a slow exposure over time rather than giant gushes of the medicine and then, kind of like that ebb and flow type of appearance. But I would say in general, this is safe, incredibly, incredibly low dosage. And then the other thing is if your insurance doesn't pay for it, we have wonderful pharmacies now that will cover it. There's Cost Plus Drug, which is a pharmacy from Mark Cuban. You can get that prescription. You can get the cream at a much more affordable rate. There are other discount pharmacies, but you can also use compounding pharmacies where they actually take the estrogen pills and they compound it so it could be put in a cream form, and it's more affordable. So more like $30 a month rather than having a very expensive, multiple hundreds of dollars a month. So there are avenues to get it if you do a little bit of research.
Fantastic. I'm going to answer the remaining questions from Katie and Gary. Just Gary with our Achilles tendon person. He has a happy ending. He said, just for our information, after about 12 years of pain from the Achilles tendon, Gary, you poor person. I'm a runner and I can't stand Achilles tendon pain. He started taking magnesium glycinate, and it has given him tremendous relief. And so for our pharmacology friends here, is there any connection that you know of? And again, he took magnesium glycinate. Well, we're learning from Gary.
And honestly, I don't know of the association, but I think being proactive for your health and doing the things that make you feel better and being active and keep trying are the keys. And I tell my patients, I don't always have a medical explanation as to why you feel better or something works, but that doesn't mean it didn't work for you. It absolutely did. And I just want to give Gary kudos for keep trying, staying the course when he suffered such a terrible complication from this.
I'm going to go off script here and ask a couple of questions. I'm going to give you both a scenario. Actually, this happened in my own household. Is Dr. Clifton, you mentioned baseline UTI. Can you reiterate what is baseline and what is not baseline? Just so our people listening in can really just have a definitive definition of what a UTI is.
You mean uncomplicated versus complicated?
When you mentioned that if it's above baseline, then you have to sort of act.
Yeah. So if you have a patient that is very ill, so you mean if a patient comes in and they have fevers, then we pretty much throw everything at the patient in terms of antibiotics. And we generally give very broad spectrum antibiotics in someone who's very ill. If you have a patient, though, that may just have some localized symptoms and you have the opportunity to try to figure this out over a little bit of time, then that's a different story. Is that what you mean?
Well, symptoms would be maybe not feeling great, lethargic.
Yeah. Those are more of the symptoms that are concerning. So if you have someone that functioned very highly and they get a lot of what I like to call flu-like symptoms, malaise, severe fatigue, fever, those can be concerns of a very significant infection. Now, that being said, the infectious diseases guidelines that I shared talk about making sure that when patients come in with a complaint of fatigue, that we just don't blame it on the bacteria. We really want to see those other bigger signs like fever or, really getting confused. People that are fatigue is so difficult because there are so many different things that can create fatigue that if we just blame it on a positive urine test, which a lot of our patients with urinary diversions will have positive urine tests, we have to be careful because we could be missing heart conditions, we could be missing neurologic conditions. There are other things that we should rule out before we just keep blaming the urine and the bacteria in the urine for all of those symptoms. So I would look at patients having fevers, really severe kind of like chills, hot flashes, or confusion. Those are real medical emergencies and they need to have urgent treatment.
So thank you for, this is so important at this moment because it happens in every household. You think your spouse has that and you're not sure. And then you're in the unique situation, which we all are, where we're not always at Johns Hopkins with this exquisite team who will take you in and give you what you need. Sometimes you're in a rural, local place. You think, oh, I need a urine sample, and you have a stoma and no one has a clue what to do. And it's really stressful for the caregiver and everyone else, because then you call your urologist and they might not, they'll see you next week and you think you have this fever. So my question to both of you, how can you produce a urine sample if you have a stoma, and is it okay to do it yourself and then bring it to a lab? Because the wait time could be devastating. I mean, your conditions are getting worse. It's not validated yet. Can you help us with urine sample collections for a population that needs it, but maybe a setup that doesn't really ready to see stomas or neobladders or whatever, our unique physiology is out there?
Well, I think one aspect is really knowing the story. If you have fevers, if you have concerning symptoms, the answer is you got to go in and get treated. And I think Dr. Singla and myself have seen a lot of situations where people have urinary tract diversions and they get very sick very quickly, and they need potentially some sort of imaging to make sure they don't have a blockage of their kidney draining downward. I think, though, when patients are empowered to realize that stinky and cloudy urine isn't always a sign to just run to get an antibiotic, that helps figure it out. But when my patients' partners or their family members say, I'm really concerned something's different, the answer is always make sure your patient's safe, that your family member's safe, and then we can figure it out later. But I want to ask Dr. Singla about how he counsels patients for urine collections, because I think, Stephanie, we talked about this yesterday. I don't hand out a lot of containers for urine collection for people to do it at home, because there is a time period that really you're going to get a good result versus get a lot of contamination. And so I do like to have patients come in for that, but I'd like to hear from the surgeon who does these surgeries more frequently than I.
Yeah, I mean, I think, so I also don't necessarily advocate for handing out urine cups, because it tends to be very particular with respect to the nature in which the urine is collected, the time frame in which it's analyzed, and there could be a number of complicating factors that could impact the interpretation of the results. I do think that it's important. Anyone who does have a diversion should really understand their anatomy and some of the nuances that go into diagnosing a UTI properly. Especially if they do live quite a distance away from a center that does a lot of these types of surgeries. And so I think first and foremost is being educated and knowing what goes into a proper urine collection, the importance of using a catheter to obtain a sample, and depending on the presenting symptoms, like Dr. Clifton said, if it is, depending on if it seems like there may be a more serious issue at hand, then it may not just simply be, walk into an urgent care and get a urine sample and call it a day. It may be that there's going to be a more intricate workup that is necessary, including lab work, plus or minus imaging, plus or minus hydration, et cetera, which would typically need a more resourced facility. And so for these reasons, I think it's something that if someone with a diversion were to go into an urgent care setting and otherwise feels well, more generally speaking, but has maybe symptoms that make them feel like they need to get it evaluated, having that knowledge of what goes into a proper urine collection is important, but I would say probably best to have it done at the facility itself. If anything seems a little bit off from the normal, just more generally speaking, then I would say keep a lower threshold to get more specialized care.
Good answer. Thank you. So Gary, I think Gary, they mentioned Gary's question has to do with the urine sample in a pouch, but we're talking in general, don't get your urine sample from the pouch because it's likely to be contaminated. I think that's consensus there. Is that right? And then, so Dr. McConkey will answer that question for us. And finally, this has been fascinating, and thank you, everybody. Please keep, if you have questions and we haven't answered them, keep sending it to us at bladdercancer@jhmi.edu. We'll keep answering. And we actually, with Dr. Clifton, we had a session on that largely was about women's health and UTIs yesterday, and there were many follow-up questions that she got in her inbox this morning, for which we thank you, because this is really important information that's seldom discussed in depth, and it really matters to all bladder cancer and UTI patients. So thank you for this. Katie, who is one of our loyal followers, I know she has a conundrum for you. She says she was diagnosed with cystitis, and which was confirmed in 2020 via biopsies. Her urine cultures have come back negative, but she still gets pain on and off. What do you recommend she do with that? Her cultures are negative, but she still has residual pain. What suggestions do you have for her?
Well, I don't think Dr. Singla is going to jump on this one, so I will say that this goes into the bucket of not blaming everything on a urinary tract infection. There are, of course, fungal infections, viral infections that can happen, and they're not captured with a bacterial collection of urine. Again, that's usually you see other indicators. Now, cystitis, just to make sure that everyone's talking the same language, it just means inflammation of the bladder in some sort. It doesn't tell us why or how. And so it's very common that when we do these biopsies, and I know Dr. Singla and myself, we both do these biopsies quite frequently, we will see signs of inflammation in the lining of the bladder. And that's what that cystitis means on the diagnosis. It's a very general term. It does not mean one thing or another. It just means there's a sign of infection, inflammation. There's a sign of inflammation, not always an infection, and that it's not cancer. So it can be unfulfilling for our patients to get those results. I would encourage anyone that's still having discomfort to see someone that can do a pelvic exam. Also, if you're postmenopausal, please consider some vaginal estrogen. This can help bladder symptoms independent of preventing infections. So talk to a caregiver or care provider that you have to really have that conversation. And if they say, I don't prescribe it, I don't know what you're talking about, find someone else who's familiar with that therapy, because it can do a lot of good. I gave you the list of pelvic floor physical therapists. I can't tell you how many people that have had surgeries in the pelvis, and their muscles, the pelvic floor is a group of muscles that support all of your insides, and they get traumatized through these procedures that we do, through events such as urinary tract infections or removal of the uterus. those things impact the pelvic floor. So if you do have continued pain, our guidelines in every possible direction suggest you go to someone trained in pelvic floor physical therapy with a specialty in pain. Don't just go down the street to someone who does pelvic floor physical therapy, and please don't do Kegels. Do not go home and read an insert on doing Kegels. Please go to a specialist that can help direct you, because when you have pain, that's a different beast and it's managed a different way. And a lot of the time it's relaxing the tight muscles that are in spasm, and it is doing that through relaxation exercises and kind of relaxing that tension, thinking head to toe, relaxing stress in general, acupuncture, but also they go internally and they rub out those tense muscles. So it's like a deep tissue massage for your pelvic floor. And if those things aren't done, you haven't done enough to help improve your symptoms. And I think we don't have enough pelvic floor experts in that area that can provide care for everyone that needs it. So I would try those avenues first before I would go down the diagnosis route of a chronic pain condition, because until you rule out these things that can be treated, I wouldn't label it with a chronic pain condition that requires, well, it's not going to have a cure and requires a lot of invasive therapies. So that's just my 2 cents. I would try to expand on those 2 ideas.
Fantastic. Well, thank you all for your fantastic questions, but most of all for Drs. Clifton and Singla and Dr. McConkey for this wonderful presentation. I thought it was super informative. I hope you all enjoyed it. It has been recorded, so you can go back and take a look at it or share with other friends or colleagues who would wish they had seen it. And there's some valuable tidbits of information. We learned a lot today, and only because of you. And so thank you again. And we will be seeing you. Our next one is next month, I think. So thank you all and have a great evening, and extra thanks to Dr. Clifton and Singla.
Likewise. Thanks very much, folks. And for those of you who enjoyed this, stay tuned for our upcoming session on the microbiome. It's totally relevant to what they talked about today.
It was, a little bit, and it's so related to this. So, we are going to be experts in all things having to do with our systems, which is what we need. Information is key. Thank you again, and have a great evening, everyone.
Great evening, everyone. Take care.